Go.
Hello, everyone, and thank you for joining us on Single Payer Radio. You are listening to WFMP LP Forward Radio at 106.5 on the FM dial. Just real quick, the opinions expressed on Single Payer Radio are those of the speakers and not the station. So speaking of the speakers, my name is Mary Radford. I am a member of Kentuckians for Single Payer Healthcare, and today I will be interviewing Kay Tillow on two articles that she's written recently. One is on the Counterpunch website. You can find that there. And she's also co-authored another article for Stat News. So welcome, Kay. And today we're going to be talking about value-based purchasing and what that means and why we think that might be an issue. So Kay, welcome. Thank you for being here.
Thank you, Mary. I'm so glad to be with you to talk about this topic, which I think is really, really important.
Yeah, absolutely. And well, where I really kind of wanted to start with this was that, I think a lot of people don't really know about value-based care. I think that one thing, the name is very misleading. It sounds, it's dressed up to sound very appealing because the word value makes it sound appealing. But can you just kind of give us like what's the down and dirty of value-based care? What are we really talking about here?
Okay, well, it's a little difficult to explain, but it's really important that people understand it because it's something that is happening pervasively throughout our healthcare system, and it has become the basis for profits, for privatization, for venture capital and private equity, and for making our healthcare system so expensive and so inaccessible to millions of our people. So let me see if I can just start with going back in some of the history. In the 90s, we had an explosion of managed care. And that was that the policy experts, that's in quotes because they're not really experts, but they claim to be, and quite frankly, they're recognized as experts. They claim that our healthcare is too expensive because patients demand too much care and doctors prescribe and carry out too much care. And therefore, that at the base of that, they claim, is the fee-for-service model where a physician is paid for performing a task, a visit or whatever, a treatment, a diagnosis. And they claim that that's the reason that our healthcare is too expensive, and that what needs to be done is there must be management that stops this overuse of care. And therefore, they're saying that that doctors shouldn't receive fee-for-service, hospitals shouldn't receive fee-for-service. They should be instead paid for the value of the outcomes. Now, it sounds like that might be a good thing, right? I mean, it sounds like if we pay for value, that would be a good thing. But the problem is the mechanism for implementing it puts into the mix the middleman, the insurance company, the manager, the private capital, the venture capitalist who manage the care. And then that sets up a new configuration where there is profit to be made if care is denied. That's the problem. And that's what we saw in the late 90s. I think people will remember we had things like drive-through mastectomies, and we had new moms and babies sent home from the hospital zippity on their way without really an opportunity to evaluate their condition, and we had some terrible outcomes. So we kind of had a rebellion in the country against managed care, which was cutting back on care, cutting back on hospital stays, cutting back on everything, and people rebelled against it. Well, that managed care was replaced by this new concept that is supposedly better, but not. It's the new managed care that we're going to pay for value rather than on the basis of a particular service. And it really, it was debated in the early 2000s, and it really took off because it was written into the Affordable Care Act. That's where a section of that act, which we all know that it was passed in 2010, and there's a particular section of that act that sets up something called the Center for Medicare and Medicaid Innovation. And inside that center, they are supposed to carry out demonstration projects within Medicare, and they're supposed to do away with fee-for-service and institute value-based care. And
Well, just to not to cut you off, but I do want to expand on this idea a little bit of value-based care, because, like, first of all, I love the concept that, like, the problem with our healthcare costs is that, like, people want to see a doctor and want to receive care. It's like that's so mind-blowing to me, is like the idea that, like, clothes are too expensive because people want to wear clothes. Like, we don't apply these ideas to, like, anything else, any other good or service in the world, but, like, healthcare is like, it's your fault because you want to see a doctor. um but, like, when we talk about value-based care, do we have a sense on, like, how are they equating value? Like, what does that mean, value?
well, they can't define it, and that's a part of the problem, is that in order to pay for value, you have to figure out some mechanism for how you determine value. And they haven't been able to do that accurately. So uh, quite frankly, there's no way to measure that mathematically. And that's one of the reasons why it doesn't work. And in fact, almost all of the experiments in value-based care are failing. I think 4 or 5 out of 54 were total failures. They either didn't improve quality, or they cost us more, or they didn't reduce the cost. So it's been a failure, but they continue with promoting the idea, and it continues to be on the agenda. And I think, the diagnosis is wrong. We in the single payer movement, we who want universal health care, we have a diagnosis. We say that it's the administrative waste and the profits that cause most of the administrative waste that is causing our system to be too expensive. And that if we remove that, which is something in the area of 30% of what we spend, and if we use that money instead to expand care to everyone and to make everybody's care better and add the dental and eyeglasses and the drugs and all the things that we need, that's the solution. It will control the costs and it will cover all of the people. There, the value-based payment movement or industry, it's now become an industry, says no, 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 no. The problem is fee-for-service, greedy doctors, and people demanding too much care, and doctors giving too much care, too many tests, too much, all of that, overuse of the healthcare system. And therefore, so they have the wrong diagnosis. They can't possibly get the treatment right.
Mhm.
And their treatment is to set up Well, I think the most popular one of what they set up is called accountable care organizations. And those bring together doctors and hospitals and insurance companies and supposedly form a network that supposedly will better coordinate the care. Really what it's doing is putting middlemen in the middle of the care, because no longer does the physician decide, I think this person needs an MRI. That has to go through someone who is in the insurance company who has to authorize that, whether that should happen or not. And when you put profit in the mix, to where denial of care or delay of care increases profit, I mean, what do you think begins to happen? And that's what we see in our Medicare Advantage plans. Those are the private, for-profit Medicare plans. And we've just gotten a report from the Inspector General at Health and Human Services that huge numbers, millions of people are being denied care that they should have legitimately gotten through their plans, or they're being asked for pre-authorizations on things that didn't need to be pre-authorized, and that delayed the care. And, you know, when you're talking about cancer or other things where time is of the essence, these delays cannot be overcome. They can't be undone.
Mhm.
And that's what, and Medicare Advantage is one of the programs that functions on this basis, that they're going to coordinate the care and cut out the unnecessary care. The reality is they're cutting out necessary care.
Mhm.
They're delaying
Yeah.
necessary care.
Yeah, like there's something unnecessary here, but it's not it's not the actual care, right? Like the thing that needs to be cut out is actually them, right?
Right. So that's where we are now. The most recent piece of this puzzle is what was first called the direct contracting entities. And that was, well, it was actually, the program came out during the Trump administration, and it began putting people who had chosen to be in traditional Medicare into direct contracting entities where there was a profit-making middleman, and it was being done without the consent of the person. It is being done. It's in effect right now. And there has been a storm of protest organized by National Single Payer and Physicians for a National Health Program and some local groups and some retiree groups and Social Security Works, a number of people who are concerned about seniors. And as a result of all of that protest, the protesters were asking to stop the program and don't put people into plans without their consent, and don't put them into plans that are controlled by Wall Street and private equity.
Mhm.
And what this movement succeeded in doing is getting them to change the name of the program.
Okay.
So,
Because my next question was going to be how does value-based care, like how is that, or is it a part of the Medicare Advantage like mechanism? Were they separate things? Or so it sounds like this is the continuation of that.
yeah, Medicare Advantage runs on the principles of the value-based care movement. It's to coordinate care, supposedly cut down on overuse, you know, that's around it. And the reality is that we taxpayers pay more for the Medicare Advantage program than we do for traditional Medicare. And yet the Medicare Advantage plans have the healthiest people and the least costs and deny the most care, spend less on care. which really a very, very bad deal. But that is indeed a part of the value-based payments that the hospitals and physicians and the caregivers are paid on a capitated basis, or mostly a capitated basis, a certain amount per member per month, which sets up that way to make the profit. Because if you're getting paid in advance and then you give less care, you make a lot of profit. Now, what they would say on the other side of this is that they're protecting you from unnecessary care, and they're keeping you healthy, and that's how they're improving the value. But it's not working. Let me give you an example of it, because this one was, I think, something that all of us can understand. Part of this movement said, when patients have to go back to the hospital after they've been in the hospital for congestive heart failure, if they return to the hospital within 30 days, we're not going to pay the hospital for the second stay. Now, what they're assuming is that there's something that the hospital did in that earlier stay that caused the need to return within 30 days. And that's not so. Congestive heart failure recurs. That's in the nature of the beast. So it most likely has nothing to do with what the hospital did 30 days earlier, but it sets up a new mechanism where the hospital now doesn't want to take the patient back. So they put them in observation, or they refuse to readmit them.
Or they send them somewhere else.
Right. So now the studies that have been done have shown that that project, what it's doing is increasing the numbers of deaths, because it's denying the care. It's put an incentive on the denial of readmission, the denial of care. And that's one of these value-based payments that's based on nothing that has anything to do with reality. Who decided that if you come back to the hospital within 30 days of having been there before, that it's the hospital's fault from the earlier admission? And that's the problem with this. It's not based on research or soundness or data or humanity. It's based on these metrics they put together. And it's a part of the terrible burnout of our caregivers, because in trying to measure value, you have to click a lot of buttons. You have to click, are you safe in your home? Have you had this shot, that shot, whatever? Screens and screens of things you're supposed to ask, which has really escalated the computerized responsibilities.
Well, and Kay, I think you bring up something really important that I want to kind of expand on too. Is you and I have talked about this before. I have a really huge interest in public health, personally, and back to this kind of idea is like, all of this is expensive because it's our fault. And so expanding out from the healthcare system into, the systems in which like we are all living under and are all subject to, is this idea that like you would have congestive heart failure, or like a patient is kind of this like autonomous like vessel of a being, and like when you leave the healthcare system or the hospital, you're not also impacted by your environment. So it's like if you leave the hospital, you're going back out into the world, you're going back out into the environment where you got congestive heart failure to begin with, right? So this idea of like, we live in this system where like people have issues with like accessing a healthy environment, nutritious food, clean air to breathe, safe neighborhoods. Many of these people, housing might be an issue, and to like look at this issue of just like you're a patient in a hospital, and then like we're going to kind of lift you out of this very specific weird circumstances of like being a patient in a room, and then like expect that to continue on in the larger society is just like it's insane. And it goes back to that thing of like healthcare is expensive because it's our fault, it's the patient's fault, it's the doctor's fault, it's the hospital's fault. Is just, yeah, it's madness.
It is indeed. And one of the things that we've discovered of this is that when you say that you're paying physicians in hospitals on the basis of their outcomes, that means that those hospitals and those physicians who serve the underserved, those people who are less affluent, those people who have less in terms of nutrition, et cetera, those physicians and hospitals get less money because you are assuming that it's something in their care that caused the patient not to have a good outcome, when the reality is all of those things you mentioned are impacting people, and those people who are less healthy to begin with are going to have worse outcomes. And if that means that the physicians who serve them get paid worse, that just makes it even worse because we're now cutting the workforce, the professional workforce that's serving the underserved. So it's just a horror, this value-based payments, but it continues to dominate. It is the philosophy during both Republican and Democratic administrations. And it is what they see as the way to reduce healthcare costs. And they are pursuing it with a vengeance. And that really is the problem. Of course, the alternative proposal is what we suggest, and that is that we do away with the profits, the administrative waste, use that money to expand the care and cover everybody under a national system that is humane and just, and begins to do away with the discrimination and the suffering that we have from all of these insurance company based ideas of copays and deductibles and co-payments and co-insurance. All of that is based on that same idea. People are using it too much. We have to put barriers in the way of people going to the doctor and going to the hospital. And all of those things are really barriers to people getting needed care, necessary care. And our whole system is set up around these wrong ideas. So we have to change it.
Yeah, I just realized something like I think the best way to explain this, and how I'm probably going to explain this from here on out when someone asks me, is value-based care is kind of like, it's like No Child Left Behind, but for healthcare.
Now explain how that works, Mary. Explain that to me. How does that?
Well, just like the idea that we're not going to fund areas that like actually need it, like especially in the case of like hospitals that serve the underserved, and taking funding away from them. So now we have to figure out workarounds, and remember, No Child Left Behind, I think they were like, teachers were like taking tests for the kids. So there's
right, because the schools who did the worst got their funds cut, right?
Right, exactly, yeah.
So it just escalated into.
So now we have to find all these workarounds instead of just giving people what they need.
Yeah, so it is indeed insane. the person who heads up this Center for Medicare and Medicaid Innovation is
Yeah, I want to talk about him. Yeah.
her.
Oh, her. That's right. Yeah. No, there was another guy I was thinking of, but yeah, let's start with her.
Okay, we'll start with her. Her name is Liz Fowler, and she hails from the insurance industry. She was a vice president of WellPoint, which became Anthem. And then she got this nice cushy appointment to serve Senator Max Baucus, and she wrote the Affordable Care Act. And she wrote into it this section, which is the Center for Medicare and Medicaid Innovation. And that's where all of these experiments are taking place that are actually privatizing our Medicare and Medicaid. And then she went back and she worked for Robert Wood Johnson, and she worked for the Commonwealth Fund. And then she was appointed by Biden to direct the Center for Medicare and Medicaid Innovation. So that's where she is now. And she is, you know, a government official, but also a watchdog for the insurance industry. And she does that job very well. And she directs that department. Right now, they are pushing this ACO REACH, which is the new name for the direct contracting entities. And they've given it a name it means realizing equity, access, and community health, something like that. In other words, now they're pretending that it's a program to bring about equity and to do away with the disparities on the basis of race and economics within our system. And nothing could be further from the truth. It's just a new name that disguises its profitability essence. And in fact, under these programs, both DCEs and ACOs, it's possible to make up to 40%, to take up to 40% in profit from the Medicare program. You know,
wow.
in traditional Medicare, you know, only 2% is spent in overhead.
Oh,
In,
wow.
in Medicare Advantage, they allow them to take 15% in overhead, and that's kind of what is true throughout, you know, the insurance world, but this can be up to 40%. And that's why, you know, everybody is getting into the healthcare business. It's the new place to make big bucks. And we have Walgreens are setting up their plan, and they own the Village MD, which is primary care physicians, and they're throughout the country. There's some here in Kentucky. CVS is getting into it. Amazon just got into it. Amazon, the biggest, the biggest and the worst. They just bought One Medical. One Medical owns IORA, IORA. IORA is a direct contracting entity. So Amazon is now into the DCEs, and with their billions, who knows what's going to happen next with our healthcare.
Mm-hmm. Yeah, I was reading about the ACO stuff, and it was a little confusing. All of this stuff I think is purposefully confusing personally. But it sounds like the ACO is going to focus more on primary care doctors and like that reimbursement. So is this like, how's this going to impact? Can you speak on that? Like the impact this will have on primary care?
Well, that's what's happening. ACOs, they say that they want to coordinate care through the primary care doctors, and they want to get primary care doctors on board with using their technology, and you know that they will then pay them a per member per month payment. That's the capitation. And that's what happens in the, you know, the accountable care organizations, is that they're trying to move away from fee for service and into capitated payments. And, you know, primary care doctors have been under stress for a long time. They're paid the lowest of the physicians, and their offices, you know, many of them have been bought up by private equity. So they're preying on the primary care physicians because they're being told that they'll have a regular income and won't have to hassle between trying to collect fees from people who have no money, that they will instead give them a steady income as long as they abide by their rules. So, I mean, that really is a big piece of the problem, is that professional workers like nurses and physicians are being controlled by those who have money in mind. And that interferes with the professional decision-making process that, you know, people in charge of our healthcare need to be able to use their heads and their hearts and not be tied by money strings to try to move in a different direction. They're going to they put restrictions like how many CAT scans you can order, how many MRIs. Well, you know, who should make that decision? And there shouldn't be the pressure from somewhere else that's based on profit as to what needs to be done.
Yeah, and I think like kind of going back to what we were talking about before with all these like kind of measures in the way that the for-profit system is shaping the process in which like care is delivered by the professionals. You know, there are, and for the listeners, I am a nurse, and there are a lot of like all these like do that you have to like click through. You know, I've got to chart whether or not this patient's a smoker, and like I might not do anything about the fact that this patient's a smoker, right? So it's like I might not be able to do, you know, I can give a patient like, and I'm happy to do it, all the smoking cessation and, hey, you know, you shouldn't smoke. Well, everyone knows they shouldn't smoke now, you know, in this day and age, everyone knows that. So it's like, it becomes, in so much as like what I would rather have is like the opportunity to provide good care and counsel for my patient, you've now reduced it to a chore I have to complete, right? And yeah, you've altered the way I care for my patient because of that.
Yeah, and that's what's wrong. You know, one of the things that happened in this recent summit on transformation to value-based care was they all discussed wanting everyone to work only at the top of their license. Do you know what that means, Mary?
No. Oh gosh.
Well, no, but think about it. See, when working with nurses and healthcare workers, I'm aware of the constant efforts to get jobs done by a cheaper classification of worker, so that, you know, if they could cut back on RNs and have more work done by aides, or cut back on, you know, down the line, it cheapens the care, but it cheapens the cost. So that's a constant pressure within healthcare. Well, what they're saying is that, you know, if a doctor doesn't have to do it, then let the nurse practitioner or the one down the line or the lab tech or someone else. So that's what they kept emphasizing at this meeting, is that don't let anybody do any task that is not at the top of that someone who has a lesser license and of course lesser paycheck do. And so I think that's one of the big things that's happening in the value-based care, is stripping as much as they can of the higher skilled professions and substituting people at lower levels to wherever they can. And, you know, I'm not against that if it's done safely, but when it's done on the basis of profit, it's not going to be safe. it's gonna
Right.
just be done.
Right.
It'll just be
Yeah.
done.
Yeah. And I mean, I think like the vast majority of people who choose to work in the health field, we are doing this out of a vocation, out of a desire to help people. But like that kind of good-hearted humanitarian part of that is your foundation, but it's like you have to learn, like you have to go to school, you have to learn things. So it's like, an aide is going to miss things that a nurse would notice. So if you stretch the nurses out too thin and give them too many patients, and now you're backlogging all of this, the aide can do the best that they can, but they don't have the education that a nurse has had, or the training that a nurse has had to like recognize problems, that are just starting to be problems before they get to be major issues that are potentially, life threatening. And it's the same with, going up the line. It's the same with doctors as well. If you're putting too much on nurses, and doctors are going to also miss stuff. Yeah.
Yeah, one of the nurses I worked with had this saying. She said that even the most excellent nurse can be overworked to the point of incompetence.
Absolutely. Yeah,
And
absolutely.
it's just true that
Mhm.
there is only so much that one human being can do, no matter how highly skilled. And they're always stretching that and trying to make it go further. So
Yeah.
that's one of the concepts within the value-based payment movement, is that we're going to cut the costs by making sure that nobody does the tasks that can be done by somebody at a lower skill and lower pay grade. So that's one of the things that's happening. And they're, of course, trying to move a lot of things to telehealth. And that indeed is a problem as well. I think that the California nurses have a campaign against home alone, about putting people at home on monitors without a real person there, and having hospital at home instead of having people where they have access to real care. And we all know how many times our computers go on the blink and have to get reset. So think about the people that are at the mercy of just monitoring technology without a human being with a heart and a head.
Right.
Um,
And an education and a skill set. Yeah.
it's
Mhm. Right.
to be
Yeah.
able to help. So it really is, I mean, they're moving towards telehealth, towards, everything, but, highly skilled people doing the care. And they're moving towards, they say that they're going to get the money to transform primary care through venture capital and private equity. Amazon,
Mhm.
Walgreens, CVS, all of these things are going to be going into healthcare. So it really is a huge concern. There are some good things to report, and that is that the movement to stop the DCEs, the direct contracting, that puts people in traditional Medicare and plans that are owned by for-profit companies. Recently, the Texas healthcare activists were able to persuade the congressman from their area, Representative Lloyd Doggett, to write a letter to Health and Human Services saying, in this program, in this ACO REACH, and don't have people put into for-profit systems without their consent. So that was a victory of our movement, and he is the chair of the subcommittee on health under the Committee on Ways and Means. And it's a big, powerful committee. So I don't know how much impact it will have, but at least he took a stand. And he took a stand because the people who cared about healthcare within his constituents pressed him to do so. So I think that's the direction that there is hope, is that if people understand what's going on and then stand up to try to get their political representatives to actually represent them, that's the area in which there is hope for us to have a different outcome.
Yeah, so just for the listeners, Kentuckians for Single Payer, we do not endorse candidates. That's not what we're about. Um, just to clarify, but so okay, have we made any headway with some of our elected officials?
Well, we have. We spoke, the congressman who represents Louisville is Representative John Yarmouth, and he did join in signing a letter that was signed by, I think it was 54 congresspersons who opposed the direct contracting entities. So that was a good thing. I don't know that he has spoken out outside of that, but that was good that he signed on to that letter. And I don't think any of the others in Kentucky have done so.
Mm. It'd be awful nice if they did. And Yarmouth will be stepping down, so he will be replaced at the next election cycle. So we'll have to see if either of the candidates are willing to also sign on for that as well.
We will work on it.
Yes, we will.
You know, one of the things that we've done is we've tried to contact the candidates before the primary and offer a free program presentation on single payer healthcare, so that all the candidates going into the primary would have the advantage of at least knowing what it's about and being able to take a stand for it if they chose to do so. So
we hear back?
well, we've talked with a lot of them.
Good.
We have talked with a whole lot of them, and we persuade a lot of them. So anyway, that's an ongoing process.
Yeah, and also we should mention for the listeners, this isn't something we just offer for politicians. We're happy to come to give education to, you know, if you have a group that you'd like to learn more about this stuff, you can. What's the best way to contact us if anyone wants to host an event where we come and do an education?
Well, they could go to our website, which has our contact information. And our website is kyhealthcare.org. And once you get there, you should be able to find my phone number and our email, and you could sign a petition against DCEs there. You can find all kinds of information on the website. But we do, you know, that's what we believe the solution is, through the public understanding the healthcare system and using their rightful human concern for making it better to change what exists politically. So since that's the way we see it, how we change it, we've got to reach out to the entire public. So we do programs for college classes or union groups or church or other faith-based groups. And we do them free of charge. We can do PowerPoint presentations. We think that once people know the facts, that they will be in agreement. And in fact, you know, the polls show that we have majority support within our country for a national, universal, not-for-profit, single-payer system that would cover every single person with no barriers to care. And that, you know, we have to get from here to where we have the ability to enact that in national legislation. And that's the rough spot for us.
Yeah. Well, yeah. So just I wanted to get those plugs in for our group real quick. You can also find us on Twitter and Instagram and Facebook, and you can reach out to us there as well. But I want to go back to something we were talking a little bit before because you brought up Liz Fowler, and I thought you were going to bring up Ezekiel Manuel.
Oh,
That's who I thought we were about to talk about.
oh, we have to talk about Zeke.
We do.
Yeah. Oh man, I don't know. Where should we begin?
Well, let's start with, I guess, his kind of backstory. It sounds like he was also one of the architects of the Affordable Care Act,
That's
and he was a keynote speaker for the Center for Medicare and Medicaid Innovation. Is he a part of that group? I'm trying to remember the article now.
He would ally himself with that group. I don't think he's a part of it, but he, he's referred to as an architect of the Affordable Care Act, as one of the people who helped to write it, along with people like Liz Fowler. And he was a health policy, I guess, an advisor or whatever. He was inside that the Obama administration. And he is he's very outspoken about what he believes in, and he is the one who wrote the article that he wants to die at age 75.
Mhm.
Because he claims that people are less creative and less productive beyond that age. Which
Speak for yourself, first of all.
doesn't give me too much confidence. He's an oncologist, so can you imagine what his 75-year-old patients think about that? But
well, yeah, I mean, yeah.
that was the what he wrote, which you would think that somebody who thinks that ought not to be let anywhere near our Medicare system,
Mhm.
where we have people at all ages who are seeking to get care. But, one of the things he does is that he very distinctly says he's opposed to single payer healthcare. And he's opposed to it because he thinks it's un-American.
Yes, that's what I wanted to touch on, because that is like, what does that mean? What does that even, and that's like something I wrote down when I was kind of preparing for this interview is like, there is this vein of like sneakiness. And that's the best way I can describe it is like, it's sneaky that like seniors are put on Medicare Advantage plans without their knowledge. It's like, it's sneaky that like, they don't really define what value means in value-based care. And it's sneaky that to call single payers just un-American. Like what does that mean?
Well, he says that it goes against America's core values, and that it removes any possibility for there to be free enterprise and a market for companies within the healthcare system, and that would be un-American if they weren't able to profit from the healthcare system. So that's his mindset. That's what he believes, and that's how he thinks. And he's a big advocate for the Affordable Care Act, and he made a speech about how he's a Democrat. He says the Republicans should stop putting down the Affordable Care Act, because if we don't fix this Affordable Care Act, people are going to get disgusted and go to Medicare for all, and then where will they be? And so he sees fixing the Affordable Care Act as the way to stop us from getting a Medicare for all system within the country. And that's what he was preaching. And he spoke at that national meeting. But you see, he's into venture capital now. He's on the board of VillageMD, and he's on there's an Oak HCFT, which is a venture, venture cap funds entrepreneurial things within healthcare, and he's on the board of that. So he's really, while he says that that he's for making healthcare the best it can be, the reality is that the program he designed is set up a way for him to make profit and for him to function within that venture capitalist world. So anyway, I don't know how old he is now. He's probably in his late 60s. So I don't know. I don't know whether
Yeah.
he'll change his view, but I think that when he wrote that article, what was it? I think it was in American Prospect. I'm not certain what that was in, but it's like, it would be wrong to say, I think everybody should die at 75. So he put it on himself, but it was a way of saying he does not value anybody's life after those years. And quite frankly, you should just move out of the way.
Yeah.
So it really, it's a despicable way of looking at the world and a very inhumane way. And people who think that way should not be in charge of anybody's health care.
No.
Oh, I think his other company is Oncology Analytics, and they do the computations for Humana to determine what kind of oncology treatment someone should have. So I wouldn't.
Yeah. I mean, yeah, it's just a really deplorable way of thinking about it, and it goes back to, this idea of like it's expensive because it's our fault, and it's just, I mean, it's I don't think it's hyperbolic to say, I mean, this is a fascist line of thinking that like there's just this large group of people that serve no value in society is awful. It's just awful.
And I've been jumping on, Zeke Emanuel, and he is a Democrat. And that's not to say that there are any Republicans in this business that
Oh,
are
for sure, yeah.
the person, Adam Baylor, was appointed by Trump to head up this department. And before he could even take the position, he had to get rid of his stock in Landmark, which was a healthcare company. I think they deal with recovery from addiction and all. I think that's what their business is. And so he had to get rid of his company before he could even take the position because it was a conflict of interest. And then as soon as he was out of the picture, he went right back into venture capital and healthcare. So that kind of revolving door between the people within the government agency making the rules are the same people who outside of it are profiting from the system. Another one, it's a guy named Will Schrank. That's his name.
That's a villain's name.
Will Schrank is the chief medical officer at Humana, but his prior position was director of evaluations at the Center for Medicare and Medicaid Innovation.
Mm.
And so there, he was setting up the rules, how you evaluate programs. And then he's out working for the company. Humana is a direct contracting entity running DCEs in a whole number of states in the country. So that back and forth, I mean, it's worse than the oil companies. We always say that's a problem, is that, that the industry gains control over its regulators.
Yeah.
And therefore they don't regulate, the industry and corporations control them. And that's what's happening in healthcare, is that the industry is synonymous with the groups that are supposed to oversee them.
Yeah.
And that's why, we have to rescue healthcare from this corporate control and give it to the people who to oversee it by people who are professional and humane and just, and don't have a profit interest in seeing you not get well.
Yeah. Well, I think that's the perfect sentiment statement to end. Before we go, I do want to make sure I plug these two articles. So the first one is titled Value Based Care, that's in scare quotes, is a pretext for privatization. That was written by Kay for counterpunch.org. That is from July 13th. And the second article that Kay wrote with Kip Sullivan and Anna Malinow, I hope I said that right? Okay. And that is entitled Value-Based Payments Has Produced Little Value. It Needs a Time Out. And you can find that on statnews.com. Yeah, so Kay, thank you so much. This was a really great conversation. I always love talking to you. So yeah, thank you for spending this time. And again, everyone, you're listening to WFMP LP Forward Radio at 106.5 on the FM dial. And the opinions expressed on Single Payer Radio are those of the speakers and not the stations. Thank you so much, Kay. Thanks for joining me today.
Thank you, Mary. And for everybody who wants to get involved with Kentuckians for Single Payer, we need you. So you can see us at kyhealthcare.org. And we would love to have you be a part of a movement that has to win to make healthcare a reality for all of our people.
Absolutely. Solidarity, everyone. Thank you.
Thank you so much, Mary.